One.
Hi, everyone. This is Professor Mulcahy again. We are working on the unit of content about antepartum at risk. This video deals with preterm labor and preterm premature rupture of membranes. So what is preterm labor? Labor is cervical change, and preterm labor happens between weeks 20 and 36 and 6/7 of gestation. It is the leading cause of fetal and infant mortality and morbidity in the U.S. And our success rates in terms of survival and intact survival with neonates is directly related to the gestational age. Between weeks 20 and 23, we know that infant is not viable, or that the neonate's not viable. Between 23 and 28 weeks, the chances are not as good as they are for a later pretermer, but we can still have survival. And by 36 and 6/7 weeks, we're really looking at a baby that's just about term. But understanding preterm labor is really important to achieving goals for healthy babies for everyone. And key to that, instrumental to that, kind of get my pointer out, is teaching women the signs and symptoms so that they know when to report it. The signs and symptoms that we want every mom to know, or every prospective mom to know, if she is having more than 6 uterine contractions in an hour, with or without pain. And we should teach her what those contractions will feel like. So they may not be painful. They may feel more like the baby's balling up, or there's tightening, or her belly gets hard. It may or may not be painful. If it is painful, it's usually described as cramping in nature, and that cramping can be intermittent or it can be constant. She may also complain of vaginal or pelvic pressure. That's another warning sign. Any leaking of fluid or bleeding from the vagina is a warning sign that we could be in labor. Bleeding can be caused by other things. Leaking of fluid is mostly associated with preterm rupture of membranes. Once that happens, labor usually ensues rather quickly, although we'll talk about that as a separate topic. And backache. One of the problems with preterm labor and getting people to seek care for it is that it mimics some of the normal discomforts of pregnancy. So, a change in the character of backache. A backache that's caused by lumbar lordosis, and having that heavy belly in front of you that your back has to support is amenable to stretching and Tylenol and heat and change of position and rest. A backache that's caused by preterm labor will not feel better with any of those things. The character will not be so much as achy as it is gnawing, and it's referred uterine pain. And that's what we're feeling with that backache. Increased discharge, especially if it's pink tinged. Pink tinged means that there is a slight amount of blood in the discharge. And somebody who says, I'm just not feeling well, and not just, not feeling well and you know what's wrong, but I just really felt awful. They should be encouraged to go seek care. So, risk factors. There are many, many risk factors. I didn't even list them all, and look how messy that slide is. Prior history of preterm delivery, or a history of incompetent cervix. Um, Both of those things, women tend to be repeat offenders with this stuff. So if we know that it exists, those are women we target for intervention very early on. We also have extremes of age. So your adolescent moms and your moms who are described as advanced maternal age, which means over the age of 35, have higher incidence of preterm labor. Those are moms we want to be a little more vigilant with. Infections. So infections of the genital tract that are in the vagina, maybe on the cervix. Bacterial vaginosis, I abbreviated as BV, can trigger uterine irritability. Sometimes it's a precursor to preterm rupture membranes. Any sexually transmitted infection, for example, when we have GC, chlamydia, uh, you know, any of those sexually transmitted infections can cause irritability, and they'll cause contractions, which will then cause cervical change and maybe birth. HPV is human papillomavirus. That's the virus responsible for cervical cancer in many cases. It can also impact preterm delivery rates. Next, we have multiple pregnancy, and this is a big risk factor. So every additional fetus that's in the uterus, any plus ones, take away 3 weeks of pregnancy or gestation on average. So in your typical pregnancy, if it were to go 40 weeks, twin pregnancy would go 37 on average. A triplet pregnancy would go 34. Higher order multiples, just keep subtracting away. That mileage varies from person to person. And, that mom is just as, it's not like the preterm labor risk starts at 34 weeks if she's carrying twins. It starts at 20 weeks. Abdominal trauma or surgery can irritate the uterus and cause it to contract. So somebody has an appendix out in the second trimester, we watch her for preterm labor. 3 or more elective abortions, particularly surgical abortions, because they involve dilatation of the cervix, which can weaken the structural integrity of the cervix. Stress. This is an area where research is finding a lot of connections between chronic or even acute psychological stress and physical stressors. Stress can be caused by diabetes or hypertension. That's a physical stress, or we can just have chronic psychological or emotional stress. It's all associated with the release of cortisol. Cortisol is thought to be one of the triggers of labor. And so stress is one of the areas that we're really trying to address as a public health issue to prevent preterm birth. Lifestyle factors, these are modifiable, and this is where the nurse can be really helpful. Poor nutrition, poor weight gain in the mom. Cigarette smoking is associated with not only low birth weight, but also preterm birth. Substance use, particularly cocaine, methamphetamine, and to some extent heroin, and long work hours, especially if there's any prolonged standing involved. These are things that we would target with education with mom and programs that we can refer her to for assistance. Short pregnancy intervals. So ideal spacing between births is about 2 years to 5 years. If we get shorter than that, we increase the risk for preterm birth and other poor outcomes. And finally, we have non-Caucasian race, especially in the African American population. And this is multifactorial. Some of it is access to care. Some of it is related to stress. Some of it may be ethnic physiologic variations in the release of cortisol, and the response of the uterus to various hormones. However, it needs to be researched and it needs to be addressed because the morbidity and mortality rate for African American neonates who are born prior to term is the worst. And it's something that really just needs to be targeted for intervention on a public health level, and also on an individual health level. So there are some things that we can educate mom to do to prevent her risk of preterm labor and preterm birth. We first have to teach her what the risks are, so that she knows that early babies aren't necessarily just smaller. They actually have more intense needs. We need for her to obtain good prenatal care, keep her appointments, go early and, as often as they suggest, and report any history to her provider and get all the, lab work and other diagnostic stuff done. Adequate rest, hydration, and nutrition. Pregnancy is not the time to burn the candle at both ends. We get a lot of referrals in terms of hydration. I just wanted to make a note of that. We get a lot of people walking into triage in preterm, having contractions in the summertime. A lot of times they're running after other kids. They forget to drink. So a simple intervention you can do is to have those little sports bottles, maybe pre-printed with the name of your health center, and give them to mom and say, you need to carry this everywhere you go and you need to be sipping all day long. Ensuring adequate nutrition is important. We can refer to those agencies we talked about in maternal adaptation to pregnancy. Smoking cessation, even smoking reduction will decrease the rate of preterm labor and preterm birth and other poor outcomes. And we also want to get mom connected to any kind of treatment for substance use if that's an issue for her. We want to teach her to avoid heavy lifting and any strenuous labor. And we want her to shorten work hours. Particularly, I see a lot of patients on my floor who work in sort of jobs that are much more manual labor. They need accommodations during pregnancy. So diagnosing preterm labor is really diagnosing changes in the cervix, although we can look at uterine activity as well to tell us what's going on. Measurement of cervical length is a technique that was really pioneered at Jefferson, I believe. And they use transvaginal ultrasound to look at the length of the cervix. If it's shorter than it should be or shorter than average, then we know this is a mom that needs to be targeted for some kind of intervention. Fetal fibronectin is a test. It's tests for the presence of a protein that forms part of a matrix in the membranes and the uterine wall. Now, a false positive is common, but false negatives aren't likely. So it has a high predictive negative value. And I'll explain that because it just sounds like a lot of big words. What it means is if you get a negative fetal fibronectin, mom has very little chance of delivering in the next 2 weeks. It's really like a 2% chance. If it's positive, she doesn't have she has a greater chance of having preterm labor, but it's not as highly predictive. There are lots of women who have fetal fibronectins that are positive for one reason or another, and then the body adapts and they don't deliver. But we do a fetal fibronectin, and there is a technique for that. I don't need you to really know this. It would not be testable per se, but you should know that the fetal fibronectin is obtained before you do any kind of cervical exam, manual cervical exam. You would get a speculum and a swab, and you would swab the fluid that's in the posterior fornix of the vagina, kind of behind the uterus or behind the cervix. And you test for that protein. It usually comes back in about 2 hours where I work. Things that can make a fetal fibronectin positive when it's really negative are sexual intercourse, any kind of disruption in the cervical canal, like a vaginal exam by a provider, anything like that. So we get the swab before we do the exam for dilatation. And like I said, it's done via speculum. The only lubricant you can use is saline for that. You can't use any KY or anything like that. It'll confound the results. A cervical exam is when a provider puts 2 fingers inside the vagina and sort of feels for the cervix and sees whether it's open and how thick it is. So we can check for changes in the cervix. Any change in the cervix means that labor has occurred or cervical insufficiency is present. External fetal monitoring and also palpating uterine contractions with your hands can give you an estimate of uterine activity. And that's a separate topic we'll cover under labor. So now we're on to some treatment options, and these are like interdisciplinary things. The next slide we'll talk about specifically nursing interventions. But for cervical insufficiency, those people who have those second trimester losses at about 20 weeks or so, there is a procedure that's called a cerclage. It is a suture. Most commonly, it looks like a drawstring. There are like 2 procedures. You don't need to know it in that depth, but it's you sew the cervix shut basically. And the suture will be cut if mom's membranes are ruptured or if she's in active labor, or if she gets determined we want her to be in active labor. But that is a cerclage, and that is a procedure that we can use to prevent that. For high-risk women who aren't in preterm labor yet, we can give progesterone supplements. And progesterone, if you remember from the last lecture, quiets the smooth muscle in the uterus. It allows it to kind of calm down so it doesn't expel the fetus. So we give a medication, the brand name for that is called Makena. And that is offered to any woman who's ever had a preterm delivery or who has shortened cervical length. We can give Makena. And that would be initiated like a little bit early in the pregnancy, around 20 weeks. If they come in and they are contracting, the first thing we want to do is to promote oxygen delivery to the uterine muscle. So IV hydration kind of increases the transport mechanism. We've got more fluid on board. And that also corrects the dehydration that sometimes makes the uterus irritable. Like I said, in the summertime, we get tons of people walking in. So bed rest is another one. And really resting in the left lateral position can sometimes help maintain good blood flow to the uterus and quiet it down. And next, we're going to talk about tocolysis. So tocolysis, for the long term, the risk of that, because these are really heavy-duty medications, the ones that are super effective, especially MAG and TERB. Long term, the benefits do not outweigh the risks. For short term, especially if we want to get steroids on board, that's down here, steroids for lung maturity. Or if we have to transfer mom to a tertiary care center because the hospital in her community doesn't offer care to a baby at her gestation, then we may give her magnesium sulfate or terbutaline. So I'm going to talk a little bit about magnesium sulfate first because mag does double duty. That's going to be your preferred agent. Now, magnesium sulfate, if you look it up in a standard drug book, is for the treatment of hypomagnesemia. What it's used for in preterm labor is that it lowers the nervous excitability across the smooth muscle of the uterus. It also works as a neuroprotective agent in the fetus, probably because vasodilation is part of that, part of its side effect profile. Um, and so we have dilation, good blood flow to the brain. And we see decreased rates of cerebral palsy and decreased rates of intraventricular hemorrhage to the baby if we administer mag sulfate for 24 hours prior to delivery. 24 to 48 hours is about what you should do for mag sulfate. It should not be given to women who have any renal insufficiency. You guys already had med-surg, so you know, and you had renal as part of that content. You know that in kidney failure, the body does not excrete magnesium, it holds on to it. So we don't want to offer that. Also, be aware that the therapeutic dose for magnesium sulfate is kind of close to the toxic dose for magnesium sulfate. So we need to monitor for signs and symptoms of toxicity, and there is much more information under that in the preeclampsia unit. Terbutaline is a bronchodilator. That was its original purpose. It reduces resistance in smooth muscles of the airways. It also acts very specifically, and oddly enough, I think it was an incidental finding, on the smooth muscle of the uterus. Now, it has the same side effects as other bronchodilators in that class, an alpha adrenergic agonist. It stimulates adrenaline. So you get increased heart rate, increased blood pressure, you get shakiness, you get maybe sometimes a sense of palpitations. Now, if you give enough of terbutaline or in a susceptible patient who's at risk for those problems, you can actually give them a crisis event. And we have sent women to the ICU with cardiac irregularities, hypertensive crisis. I think pulmonary hypertension is one of those risks. So before you give terbutaline, you need to be really careful to auscultate mom's apical pulse for a full minute. And if she's tachycardic, we don't give it. We watch the baby's heart rate. And if the baby's tachycardic, we don't give it. If the mom's breath sounds have adventitious, if she has either decreased breath sounds or she's got crackles or some other feature that we may not want to mess with, we don't give terbutaline. So those are just some considerations. Terbutaline's best use, as far as I've read and seen and done, is to quiet the uterus in a short-term kind of process, especially like, say, she's in labor, you're given Pitocin, maybe she goes into a hyperstimulating pattern where the baby's not reacting well to labor. We can give terbutaline, relax the uterus, and quiet that activity down. Nifedipine, also known as Procardia, is a calcium channel blocker. It's a little bit better tolerated, but doesn't appear to be as effective as mag sulfate, or terbutaline does not offer any neuroprotective benefits. It doesn't act as quickly as terbutaline. Terb acts really fast. You give it sub-Q, and it kind of does the job within minutes. Nifedipine is something you have to give every 4 hours orally, and you also have to check a blood pressure. It cannot be given with magnesium sulfate, so if you're giving mag sulfate for neuroprotection, you can't give nifedipine because you can cause a toxic reaction. And after we've done tocolysis, if that's indicated in this case, we can administer some agents to improve neonatal outcomes. Now, we already talked about mag sulfate and neuroprotective benefits. I'm going to talk a little bit about betamethasone. Betamethasone is a steroid, also known as celestone. We give it intramuscularly. People find that it is kind of aggravating. It does burn for a little bit. They can point to the spot maybe a month later. It is given in 2 doses, either 12 or 24 hours apart, depending on the preference. The neonatologist usually consults with the OB, and depending on how much time you think you have. And what it does is it matures the fetal lungs. Just as a side note, and something you should know because steroids are everywhere in every area of medicine, steroids can increase the white blood cell count, they can mask an infection, and they can increase blood glucose. So if you're taking blood glucose for other reasons, just be aware that that might interfere with your results. So a few things in terms of education and prevention. Teach mom the warning signs. We already said they should really be on every refrigerator, all the danger signs of pregnancy. And as we go through different areas of content related to high-risk conditions, we'll see that there are many warning signs in pregnancy. And if a woman does not know that they are reportable and that they are not a normal feature of pregnancy, she may miss something important. The prevention, we've already talked about self-care. We are also responsible for assessing mom. The doctor's not the one at the bedside all day. We are. So we want to make sure that if mom's reporting increased contractions, let's say she's inpatient, that we put her on a monitor and we palpate those contractions with our hands, and that we're looking to see how the fetus is tolerating whatever's going on in there. And we're going to monitor for those adverse effects of tocolysis. If it's mag sulfate, I want you to kind of wait for the preeclampsia video because I go into a lot of detail with that. And then we're going to prevent complications of bed rest. Bed rest is not necessarily a benign intervention. It's efficacy as a way of arresting or improving a lot of these high-risk conditions is sort of questionable. There's really no good studies on it because in order to do them, you would have to withhold that treatment from other people. But bed rest is not a benign intervention. You probably know that from other areas of specialty areas in nursing education. Biggest risk that we worry about is DVT. So we're going to put SCDs, those compression stockings on the mom. They hook up to the pump. We're going to teach her how to pump her calves as a leg exercise. If she can get up to go to the bathroom, we encourage those bathroom privileges. We hydrate well. Make sure that her blood isn't overly viscous. And we may give Lovenox. Those would be things that we would do. We also have respiratory complications from bed rest. So instead of spirometry, get mom to expand those lungs. She's not going to be working against gravity if she's not walking around much. And then we have other things that are sort of more in the realm of side effects of bed rest. We have constipation. Peristalsis slows down when there's not as much physical movement. And so we want to increase fluids, increase fiber, offer Colace if we need to do that. And then you just have things like boredom and depressed mood that come with bed rest. And it also is like a lifestyle thing. If women have other children, bed rest can be hard on them, or if they have a job and they need that income, it can be hard on them. So helping them cope with those things is also important. Okay, so that's our discussion of preterm labor. Now we're going to talk about a different condition that's kind of related. It's called preterm premature rupture of membranes, and it's exactly what it sounds like. The rupture of the amniotic sac prior to 37 weeks of gestation. And the signs and symptoms are very obvious. You get a leaking of fluid from the vagina. It can be a gush, it can be a trickle, it can be constant, or it can be intermittent. But women should know that there is any leaking of actual fluid is not normal. Sometimes women will have a little stress incontinence and they're not sure if they are leaking fluid from the vagina or if they had a little urinary incontinence. It's still worth getting checked out. Some women will have a very watery type discharge, still worth getting checked out. And we'll see it, there are certain characteristic signs when the membranes rupture, which I didn't go into, but ferning is one. If you were to put a little sample of that fluid on a slide, it would look like a fern or icicles. There's nitrazine paper is not terribly accurate, but we still use it. If it turns blue, that's usually an indicator that it could be ruptured membranes. And if you see fluid leaking from the vagina, pooling in the vagina, if they do a spec exam and they see like a puddle of fluid inside the vagina. Also, you might see oligohydramnios, which is you get an ultrasound and it doesn't look like there's any big pockets of measurable fluid. That would be another indicator that your membranes are ruptured. So managing PPROM, we have two ways of doing it, active versus expectant management. It's all risk versus benefits. So if we have a gestational age that's remote from viability, remember that those membranes seal the contents of the uterus off from infection. So if we're very remote from delivery, it's 18 weeks, it's 20 weeks, and you have rupture of membranes, it's really not worth keeping that patient pregnant anymore. There is no chance that this baby's going to be viable or survive. Even if it does, it doesn't have enough amniotic fluid to expand the lungs. It will have hypoplastic lung syndrome, and the chances of sepsis are not worth. You can lose a mom. We had a maternal death once from sepsis due to PPROM. If there's any active infection, mom is febrile, her white count is elevated, she's got tenderness in her abdomen, any of those things would mean that we need to deliver. If we decide we're going to do expectant management, there are a few things we do to influence the outcome of the disease or the condition. Number one is prevention of infection. This is where you're going to teach mom to do a lot of hand washing, even before she goes to the bathroom. Some providers or clinicians suggest that we don't use toilet paper. I'm one of them. I kind of go with the whole squirt bottle thing, and using a clean, soft, like towel, not necessarily a cloth towel, but we have these little like wipes. Because toilet paper leaves little remnants that can stay behind and be a little source of infection. Make sure that she's wiping from front to back always. If she's wearing a pad, she needs to change that pad fairly frequently, every 2 to 4 hours. We do sometimes manage PPROM with bed rest, benefits of which are, questionable, but you would manage the bed rest. And then assessment of uterine activity and fetal well-being, just like for preterm labor. The only difference is that when mom's membranes rupture, if the baby's head isn't plugging that cervix, you can have a cord prolapse. A lot of times labor will follow PPROM within, say, 48 hours. Some people can stay pregnant for weeks. But at this point, we're going to give antibiotic therapy to prevent infection. And we're going to administer other agents to improve neonatal survival, and that's your betamethasone and your mag sulfate, if you can get them in, and the baby's viable. Okay, and nursing care, education, teach mom the warning signs, leaking of fluid, hygiene to prevent infection if she is ruptured, again, wiping front to back, squirt bottle might be a better choice than toilet paper, and prevention of anything in the vagina. I didn't mention that on the last slide, but we do minimize vaginal exams once the membranes are ruptured. Even if we're using sterile gloves, the chance is higher with every time we go in and disturb things. So obviously, if she's managing this at home, and very few women do manage it at home, but in some communities, that's more the standard of care. Any sexual intercourse or insertion of anything, no douching, nothing in the vagina at all, period. Anticipatory guidance. Here are the things that may happen. You may stay pregnant until 34 weeks, or you may go into labor on your own, and we won't stop that because the risk of continuing the pregnancy is increased infection. Or we might see signs of infection and decide to deliver. Or, we might see that the baby's stressed out because either there's a cord prolapse or there's cord compression. And any of those things would get your baby an earlier birthday. Letting her know that, she's going to be monitored for the remainder of this pregnancy is also important. External fetal monitoring will show us any changes in the fetal heart from cord compression or cord prolapse. They'll show us if mom starts to contract. And communicating any changes to the provider. Obviously, if you're the nurse assigned to this patient, any little thing that gets your antenna up, if you can back that up with some evidence, give good ASPAR.